So welcome, everyone. My name is Cassandra White. I'm a cultural and medical anthropologist, professor at Georgia State University in Atlanta. And my co-chair today is Dr. Wim van Brakel. Do you want to introduce yourself briefly, Wim?
Well, it's good afternoon. My name is Wim van Brakel. I'm a medical director at NLR and member of the steering committee at the LRI. So I'm pleased to share this with you together, Cassandra.
Okay, thanks. And I'm excited to introduce speakers on this panel related to stigma and mental well-being. And we know the complex nature of leprosy-related stigma can negatively affect mental well-being and in turn mental health issues, which often prevent people from fully participating in family and social activities and can be stigmatizing in themselves. So during this session, presenters should have your cameras on for the presentation. Please mute your microphone when you're not speaking. We have presentations that are 8 minutes with 6 minutes for questions after. And the audience, y'all can post your questions in the Q&A chat box. Then the audience can also vote on the questions they want answered by clicking thumbs up. So I'll introduce each presenter. Okay. Let's go ahead and get started with Marlies Visser of Vrije Universiteit Amsterdam. And the presentation is Capturing Culture-Specific Stigma Dynamics by Understanding What Matters Most to Inform Generic Measures to Assess and assess approaches to reduce stigma. So thanks, Marlies.
Thanks, Cassandra. Yes, hello everyone. My name is Marlies Visser. I'm from the VU, and I will be presenting the What Matters Most project on behalf of the whole team. So we set out to capture culture-specific stigma dynamics by understanding what matters most. So quickly about the background of the study. So previous studies have identified that there is a lack of insight into how to really take on board culture in the assessment and reduction of stigma across contexts, while culture can really shape the way stigma is experienced and the impact that stigma can have. So what we did in this project is that we applied the What Matters Most framework, which is developed by Lawrence Yang and his team. And this framework adds this concept of moral experience to stigma theory. And moral experience means that what is most at stake in a certain context. So a cultural activity that people want and need to participate in to be valued in the community, say becoming a mother, providing financially for the family, for example. And these cultural experiences may in turn shape stigma. What is different from this theory is that it's relevant to all individuals in a community, so not only those who experience stigma, for example, and it also can point to ways for stigma mitigation. So if people are still able to participate in these key cultural activities, this may actually also be point for interventions to reduce stigma. So our project set out to increase insight into the approaches that are culturally sensitive and approaches to assess and reduce stigma. And this was focused on 3 conditions: leprosy, depressive disorder, and lymphatic filariasis, as well as 3 contexts: Indonesia, Nigeria, and Nepal. So the broader study is a mixed method study, but for today I will be presenting the findings of the qualitative study mainly. And in this qualitative study, we set out to explore what matters most, what does this mean per context, and how does this shape stigma in each context. We did so by interviews and focus group discussions, so qualitative methods. And we included people with stigmatized conditions, so any of these 3 conditions, their family members, health workers, as well as local researchers or experts. And we conducted then thematic content analysis in teams. So an example is on the picture. This was our analysis for the Indonesian part of the study, and we worked together with a team in Nepal and in Nigeria as well. So what we included in a total of 305 respondents over the 3 contexts. So examples of data collection is provided in the pictures. So this came down to 120 interviews and 31 focus group discussions in total with the various groups. So what did we find? So we first set to identify what matters most in each context. And you see that this already is slightly different, or there's nuances to it per context. So for Cirebon in Indonesia, we found this mutual respect and community contribution, also referenced as gotong royong, as key in this context. And if you're not able to participate in those activities, this shaped stigma, basically. For Enugu in Nigeria, this was having a family and children, as well as appearing clean. While in Nepal, in far western Nepal, maintaining this personal and family status came forward. And in Nepali, this is called ijat. And this is the specific context I will be further diving into for this presentation, what we found, basically. So we focus specifically on leprosy in this context for various reasons that I won't be addressing for this presentation. So what we did find is that, in line with other research from the context, leprosy stigma is rooted in cultural beliefs. For examples are that it's karma or a punishment from God, for instance. It was seen as a fatalistic belief, so predetermined. And this added to the stigma that was experienced related to leprosy. And when respondents described stigma, the word apahelana was used often. And this translates to English to disrespect or to disregard. And this could have far-ranging impacts on a person's life, either in the family or the community. And because of experiences with apahelana, so discrimination, and also the fear of experiencing this, many of the respondents shared, so also the people affected by a stigmatized condition, but also health workers shared that leprosy was often concealed. So going back to this, what matters most, so this was this personal and family status, ijat. We could see that if one was affected by leprosy, this could, if that disrupted one's achievement of ijat, this could intensify stigma. And the ways that this worked was, say, if a person is affected by leprosy and their gendered family capabilities were disrupted, they experienced more stigma. So this can be household capabilities, which was specifically relevant for women, or this could be one's ability or to financially provide for men specifically, but also one's prospects in marriage. If those were hampered by having leprosy, then stigma really was intensified. While on the other hand, we also saw, but these findings are a bit more explorative, is that if one's family supported and there was engagement of the family around the person affected by leprosy, and they received family support, then they could still achieve this ijat, personal status. So this could be a way that actually stigma was mitigated in this context. So what this means and what we found is that this family support really came forward as this key engagement that could either worsen or mitigate stigma. And this is a finding that then can provide us insight with how can we, in a culturally sensitive way, reduce stigma in this context. So based on our findings, then examples can be, early family engagement in patient treatment. Can be key roles for health workers or community health workers that engage the family in care, but also in decisions around concealment. And more structurally, we can think of, how to build capacity for family counseling at, for instance, schools or workplaces. So the interventions would be a next step our project identified what matters most and how this shaped stigma. And we're also working on creating stigma skills based on what matters most. But this has been presented in a previous year, so I won't go into the stigma skills. But I wanted to provide these examples of interventions.
Marlies, we're a little over 8 minutes, just to let you know.
I'll wrap up. That's completely fine.
Okay.
Just wanted to share some examples of how what matters most and this research can be used for stigma reduction interventions has already been done. And this could potentially also be a next step for our research. I have to wrap up. I've added some of the project outputs on the slide. What this work has what we've published, but also what we're currently working on. And we hope that in the future we can develop and study stigma reduction interventions based on these findings. And that's it for today. Thank you, Cassandra.
Okay, thank you. We have a few minutes for questions. So Vim, I don't know if there are any questions in the Q&A box.
Not so far, no.
Well, I'm going to ask really quickly, so like since I did cut you off there, like if you could elaborate on some of the other future plans for this research that you mentioned it right at the end, but yeah.
Oh, thank you. Yeah. So what we did in the project is, as I said, to identify this what matters most per context and how this can be different. And based on that, in our work, we develop ideas, right, for future interventions, like how can this be used? I think in the study on Nepal, I did look at the literature. There are, of course, interventions that use family engagement in stigma reduction, but to a limited extent. So this can be developed further. So indeed, then one of the next steps could be is that we use the work that, for example, the research that we have now from the far Western Nepali context, and create ideas of how we can use these findings in a proposal for an intervention, for example, to reduce stigma and engage with the family, because we haven't assessed it, right? It's ideas, but we haven't tested or assessed whether stigma was essentially reduced. So that can be a next step, definitely, yeah. Okay,
thank you. I don't think there's any more questions currently.
No.
At the end, maybe. So we can move on to the next presentation. Our next presenter is Professor Amina Alio of University of Rochester, with the presentation Reducing Leprosy-Related Stigma Among Healthcare Workers in Niger.
Greetings, everyone. My name is Amina Alio, and I'm a researcher working with TLM Niger on the LRI-funded project, Reducing Leprosy Stigma in Healthcare Settings in Niger. So our study objectives were to begin by understanding the manifestations of stigma in the healthcare setting, and based on what we learn, and to develop an intervention to reduce stigma among healthcare workers, and then test its preliminary effectiveness. The first year, we conducted qualitative interviews with persons affected to learn about their experiences obtaining care and to identify elements that we would need to address in our intervention. We were able to submit 2 articles based on what we learned. Working with clinicians, researchers, persons affected by leprosy, and the Ministry of Health, we co-developed the content of a training based on the elements identified in year 1. Some of the overarching elements include the fact that there is lack of knowledge about leprosy and fear of leprosy. In addition to the training content, we identified some strategies to be sure that we use during the implementation of the training, such as ensuring the involvement of persons affected by leprosy as trainers and allowing for the opportunity for testimonials and interaction with the participating healthcare workers. We also involved healthcare workers as co-trainers to work alongside persons affected to model compassionate care. The training sessions also included discussions and practical exercises. And it was also linked to the Ministry of Health leprosy training, which lasted 3 days. And we added a day and a half for the stigma portion and for the practice portion. In year 3, we tested the curriculum and processes with 10 healthcare workers. The analysis of the pre and post data from the testing of the intervention indicated that our qualitative data showed increase in knowledge and reduction in stigma. However, the quantitative data showed increase in knowledge, but no real change in stigma. So given the discordance between the qualitative and quantitative results, we held discussions and found out that in addition to social desirability issues, they felt that the survey was more like a test and that they were supposed to provide the right answer. They felt pressured to provide the right answer rather than their own opinions. So we changed the wording on some of the questions and we separated the knowledge questions from a second survey that we called Perceptions About Leprosy in Society. So on the pre, we also wanted to establish their opinions of stigma in society and in the healthcare setting in general. And the other sections were administered pre and post and asked about their own personal opinions and behaviors. So far, we've had 2 implementations of the training, and we have covered over 40 healthcare centers from 4 regions for a total of 66 healthcare workers, plus the 10 that were part of the pilot. They were all from different levels of nursing and they were also physicians. Our second training was just conducted in March this year, so we have not yet fully analyzed the data, but can present you with preliminary findings based on descriptive analysis. So we had mostly men, which actually reflects the workforce in Niger. We had a pretty even distribution of education level, indicating that we had clinicians of various levels. Most had never had any type of training or education in leprosy. About a third had treated leprosy or someone with leprosy before, and a few were not sure. And 13% reported that they had someone that they knew well who had leprosy. So we do know that stigma towards, community stigma towards leprosy is quite high in Niger, but we wanted data to confirm that fact. And despite their hesitation to talk negatively about their own society, we can see that healthcare workers still reported a high level of stigma in the community, and most confirmed that leprosy would cause social problems for the family of the person affected by leprosy. As for stigma in healthcare settings, the hesitation to report about stigma was even greater, but many still recognize that there are clinicians who stigmatize and discriminate against patients who have leprosy or have disabilities associated with the disease. 27% said that healthcare workers would hesitate to care for someone affected. 37% would be concerned about caring for them. And about half would really worry about contracting leprosy while treating patients. So based on the qualitative data we analyze, we can definitely attest that these numbers are most likely an underestimate of the reality. So based on pre and post intervention assessment, knowledge about leprosy significantly increased based on paired sample t-tests, and qualitative data confirmed this increase in knowledge, with participants confirming that they learned a lot and that the knowledge they gained changed their perceptions of leprosy. Stigmatizing behaviors by healthcare providers significantly decreased post-intervention compared to pre. Participating providers describe how the training helped them better understand about the myths on leprosy. And one clinician said, before this training, I thought leprosy was hereditary and highly contagious, with social beliefs, i.e. divine punishment, even though I am a healthcare worker. So they learned about treating patients affected like any other patients, and even better because of the extra social pressure placed on patients. There was also a decrease in personal stigma pre and post intervention. On the post test, almost all said that their knowledge highly increased. And almost all said that their perception of persons affected changed. And this is a female nurse that stated, but now I will be the first to speak out against any form of stigmatization and will be more vigilant at detecting cases for early treatment in order to avoid as many sequelae as possible. Another stated that they had a negative image of patients with this disease, and now they better understand that it's one like any other. So we did have some challenges that we faced during the implementation of our project. The most important challenge being the coup d'etat in Niger that brought about many changes in processes and bureaucracy and changes in the cost of training, which quadrupled from what we had planned. We decided to revise our intervention from a randomized control trial to an observational study. Even though RCTs are the most desirable design for testing intervention, there are still some advantages to observational studies, including the fact that it still provides real-world efficacy, and we were able to train more healthcare workers, giving us a larger sample size than originally planned. So we are in our last year of the last implementation, which was in March. And we'll spend the rest of the time on analysis, writing, and dissemination. And we also plan to finish editing and formatting the curriculum prior to presenting it to the Ministry of Public Health for use in their trainings, because this was done in collaboration with them so that they can continue to use it post-intervention, post-project. I would like to acknowledge our team, the participating clinicians, the persons affected by leprosy who helped with the training, and a special thanks to the Leprosy Research Initiative for their support through this project. Thank you.
Okay, thank you so much, Professor Amina. I saw that there were questions in the chat that might have come in at the end of the last presentation. I'm not sure if they were, I believe they were for the first presenter. And
That is correct indeed, Cassandra.
okay, maybe we should hold off for the
There
end.
is one question that has just come in that says, thanks for the presentation. Can you elaborate a bit more about the training content other than leprosy knowledge? How did you train healthcare workers in providing compassionate care? Will the curriculum become available with public access?
So I'll start with the last one. Yes, we will make it available to anyone who's interested. That's why we're trying to format it so that it looks presentable to everyone, getting it professionally done. As far as the training content, it included information about leprosy, of course, but we also talked about the appropriate language to use because a lot of the findings from persons affected by leprosy stated that the language used by the healthcare providers was very stigmatizing. So we talked about that and the impact of stigma on patients. And we used the stories of the persons affected who were present to really delve into that issue and provide real life examples. And having the contact with person affected was definitely influential. And compassionate care, it's really, again, about, first of all, dispelling the myths and making sure that they understand that this is a disease like any other that can be cured, and that these patients face extra stigmatizations and problems from society and deserve to be cared for holistically. So not just the disease, but also caring for their emotional states. I hope I answered all the questions. I think.
Yes, I think so. Thank you. And there was another question, but that is more or less the same as about curriculum being made available more widely. So I think we've covered questions we've had so far. Indeed, I suggest that the earlier questions we keep until the discussion at the end.
I have to specify that the training is in French. So, yeah.
Okay, if there's no other question,
I guess we should move on. Huh?
we'll move on, yeah, to the next presenter. And it is Mr. Anil Kumar from NLR India and Compassion Training for Reducing Stigma and Improving Quality of Care for Persons Affected by Leprosy.
Thank you. Good evening all. My name is Anil Kumar. I'm working as a project coordinator in NLR India, Bokaro, Jharkhand. And the title of my project is to Compassion Training for Reducing Stigma and Improving the Quality of the Care for the person affected by the leprosy. Compassion, here something about the compassion. The compassion is vital for the quality health services, and it is emphasized by the WHO as a part of universal health coverage. However, people affected by the leprosy often face poor health and stigma from the provider. And without compassion, quality care is not possible. Our main research question of this study is to what extent can compassion training that specifically addresses stigma, improving compassion and quality of care offered by the healthcare worker to the person affected by the leprosy or the stigmatizing health condition. Other stigmatizing health condition, it's also our main object, and our primary objective is to study the effect of the compassion training on quality of care and stigma. The method we used for this is the mixed method approach divided into the 3 phases. It's exploration, intervention, and implementation. In the exploration phase, patient and their family and the healthcare provider shared experience on the compassion through focus group, or in-depth interview, and survey. In the research phase, we began with the we collect the quantitative and qualitative data, and the result captured in human flourishing scale, care measure scale, SARI stigma scale, social distancing scale, and POMIR compassion scale among the person affected by the leprosy and the healthcare provider, and the result informed the adoption to the hiring the module. These are few data of all the tools we used in this compassion care quantitative or qualitative data. These are the human flourishing scale. Its main score is 68.6. And in care measure, it's 30.4. In SARI stigma, it's 18.4. And it's in social distancing scale, it's 2.5. And in POMIR compassion scale, it's 69.44. In all these 5 tools, we use human flourishing and care and SARI stigma for the patient affected by the leprosy, and social distancing scale and POMIR scale for the person for the healthcare worker. Our intervention phase included regular review meeting with the between the NLR, IF, and Piramal team and Amro University, the task force for the global health and NLR, and conduct to take the progress. Based on the initial feedback, Piramal Foundation developed 3 training modules. One for facilitator guide, second is for medical officers, self-help guide, and third is for paramedical workers, self-help guide. This draft module were piloted and tested in December 2024 with 20 medical officers and paramedical officers, and also A&M, a few A&M are also included in this pilot training. And the module have been revised based on the feedback, and Hindi translation in the translation is now begun to finalized. It's on the process. I think it's final within a week. And in our first training, the training has begun in March 2025 with the multiple batches for both medical officers and paramedical, involving approximately 18 participants. Medical officers in 3 batches and paramedical workers in 1 batch. The first batch of medical officers training occurred during 3 to 5 March 2025. The first and our second batch is now just coming in 15 to 17 April 2025. The approval is taken by the DLO and a civil surgeon, and it's happening 15 to 17 April 2025. In our first batch, the total number of medical officers are 19 medical officers are participated from all over the block of Bokaro, and the training was conducted with the help of district civil surgeon and district leprosy officers. And the 3-day training was transformative and impactful, and integrating mindfulness, compassion discussion, and a practical strategy to enhance doctors' self-awareness and emotional management, ultimately reinforcing their commitment to compassionate leprosy care. These are our timeline of the coming year, and on this timeline we do the compassion training till the end of June. We complete the compassion training and follow up the assessment, survey, and data analysis and advocacy. These all are happening this year, and it will be completed in the end of the year, December 2025. I would like to thank you, District Health Officer, Medical Officer of Bokaro, LRI, for providing resources to conduct the study, Amro University, FACE, Central Institute of Psychiatrists, Jharkhand, and IBAS Global, Bangalore, India, for this training and project. Thank you.
Thank you so much. Are there questions in the Q&A? And if you haven't put them in, you can put them in the Q&A chat box.
Yeah, we don't have any specific for this presentation yet. So give people
Yeah, wait for a second.
half a minute to type anything. Maybe in the meantime, if I can ask Anilji, during that compassion training, how did the participants respond? Did they see this as an important issue? Were they happy to learn about it? How was the response?
In the first batch of compassion training, it's a good question, sir, because the finding is very important for us for the next batch of medical officer compassion training, and all the medical officers are very happy, and they show that this type of training they never ever taken in any facility or any wherever he has a posted. So this is the first time happen in her life of this type of training, and it's very relaxable and it's very calm, and it's help to understand how we implement the compassion in the healthcare facility for the patient affected by the leprosy, and how we make the action plan against this, and how we reduce our hyperness when we hyper and we are not in well-being stable. So how we can how it's helped to calm down. So it's very good, sir.
Well, I guess that the compassion training element is not leprosy specific, right? And did they understand that they could also use this for any other patients?
Yes, sir. They know, sir, ki it's all about the compassion, to implement the compassion in the facility, to help the patient, whether they are leprosy patient or the other patient. So how they can treat the patient and how they behave the patient to know the condition of the patient. So it's they know that it's not for the leprosy, it's for all the other mental and health condition.
Could I ask then, did it change their perceptions of anybody's perceptions of leprosy itself, like in the Dr. Alio's presentation in Niger as well, like kind of shift people's attitudes?
Yes, I think because first I told the doctors our first batch, all are the medical representative of her blocks. So all are the MOIC of in this first batch, and they know it's very important training, and it's the first time they taken this type of training. So they think that it's very good for the patient affected by the leprosy or the other health condition. So they know it's good for us.
Great, thank you.
Okay. Yeah, I think we don't have any more questions, it seems, Cassandra. So over to you. And thank you very much, Anil.
Thank you.
Thank you, sir.
Okay, our next presentation, Dr. Moges Wubie from Debre Markos University, assessing the effectiveness of family-based approaches aimed at prevention and sustainable self-management of disabilities, impacting the quality of life, mental well-being, and participation of people with leprosy, podoconiosis, and lymphatic filariasis, and their families. Thank you.
Okay, thank you very much. Good afternoon, all of you. My name is Moges Wubie from Debre Markos University and a PhD research fellow from the University of Humanistic Studies in the Netherlands. I will present our research project entitled Assessing the Effectiveness of Family-Based Approach aimed at the Prevention and Sustainable Self-Management of Disabilities, impacting the quality of life, the mental well-being, and participation of people with leprosy, podoconiosis, and lymphatic filariasis and their family in the Amara region. The project start date was October 2020, and the project in the date was September 2023. So we asked no cost extension up to March 2024. However, because of a number of reasons, still now it's extended. We are not accomplished the final write-up anyway. So these three diseases, leprosy, podoconiosis, and lymphatic filariasis, is a three neglected tropical disease which has its own pain, unless otherwise early diagnosis and treatment may lead for the impairment, the disability. The impairment and the disability has also their own effect or impact, like stigma, discrimination, mental health effect, participation restriction, and also the economical impact. Overall, this also affects the quality of life of persons affected by the three entities. Also, it's also a burden for the family quality of life of the family. Our justification is a simple intervention of self-management is effective. Most impairments at the beginning is preventable. Simple methods exist for the self-management that can be practiced at home. But challenges is not consistently practicing this one. Based on the nature of the disability, lifelong practice is needed. What challenges just day-to-day routine of this practice. So another approach is very important, self-care group. This is successful, but still this has their own challenges due to limited long-term sustainability, problem in accessing such a group. Again, formation of a group is not practical due to private matters, financial or geographical barriers. So we hypothesized using a family-based intervention, we can alleviate the disability as well as we can improve the family quality of life. So previously we explored and piloted a family-based intervention, and we came up with a good result, but in order to say effective, we were in lack of just the comparator group. So unanswered question here, as you see here, is a family-based intervention effective or not compared with the usual care and practice. The other also is a family-based intervention sustainable or not. Our objective is to assess the effectiveness of a family-based intervention aimed at the prevention and sustainable self-management of disabilities, impacting the quality of life, the mental well-being, the participation of people with leprosy and podoconiosis or relief, and their family members. Here is our study area. As you see here, the study conducted in Amara region. On the right part of the slide, the upper part surrounded by the blue color in the two zone. At the beginning, we were selected 3 waradas, but because of the limited number of grade 2 disability, we added at the lower, the red circled 3 districts. So in general, we selected 6 waradas from these 6 waradas grouped into 12 sites, 6 sites for the intervention and the 6 sites for the control group because of the nature of the intervention. So we used a cluster randomized control trial study design. At the beginning, we were collected 840. We planned to collect 840 for the baseline data, and for the follow-up 630, 420 persons with disability, and 210 family members for the follow-up. So we used 2 questionnaires or 2 tools for the family members. Family quality of life and knowledge, attitude, and practice data have been taken from the family members. Family quality of life, knowledge, attitude, and practice. The other stigma assessment and reduction of impact, patient health questionnaire, participation restriction, and clinical data collected from persons with disabilities. The other also qualitative data also collected. The intervention has 3 components: self-management of disabilities, economic empowerment, and psycho-social support. As you see here, we are repeatedly measure at the beginning of the intervention the baseline data. After 5 sessions, the second in order to assess the effectiveness, and after 1 year just to check whether this approach is sustainable or not. So a number of activities performed during the intervention time is just rigorous health education is given, assessing the clinical data, status of the patients, demonstrating how to able to just manage the disability, and also necessary materials is given, including shoe. As you see here, the last map, the figure, shoe were distributed for the patients. Just based on that, the baseline data manuscript was developed that has their own purpose. That just assess the level of the family quality of life, again comparing this within the groups, as well as just see the association between family quality of life, SARI, P-scale, and PHQ. As you see from the first row, family quality of life of total score from 25 up to 125. The green one, just 75.5 people with disabilities by LF and leprosy and podo. Whereas again, in the last, as you see here, again, 75.2, there is no statistical difference based on the independent sample t-test among the persons affected and the family members. But there is a difference between the leprosy case and podo and LF cases. Mainly podo and LF cases more severely affected by the compromised family quality of life. If you see SARI participation scale in mental health, just written by the red, 24.9, 24.8, and 11.1. When you compare between the podo-LF and the leprosy cases, more affected by podo or LF cases. So based on the independent sample test, there is a significant association between LF and podo with the leprosy when you compared it. Again, we conducted the linear regression models, 2 linear regression models for the persons affected and the family members. The first for persons affected with disabilities, as you see here, just surrounded by green color, which is age and type of leprosy is positively associated with family quality of life, whereas stigma and participation restriction surrounded by red is just negatively associated with the family quality of life. When you come to the family members, the regression analysis result, type of disease leprosy, student or unpaid work, marital status single, and residence rural were positively associated with the family quality of. This is just in detail discussed in the manuscript. When you come to the conclusions of the baseline result, our finding indicates that the 3 entities created a moderate burden on family quality.
I think we lost connection, or it froze for a sec. Next presentation by Dr. Ngozi Murphy-Okpala from Red Aid, Nigeria, and it is participatory development of audio-delivered interventions and written material and assessment of their impact on the perception and knowledge of and attitudes towards leprosy, cluster randomized trial in Nigeria. So, Ngozi, thank you.
Thank you very much, Cassandra. Good afternoon, everyone. I'm pleased to make this presentation on behalf of our team. I'm Ngozi Murphy-Okpala. I'm a program manager with Red Aid, Nigeria. I had the privilege of leading this project. And I'm just going to be sharing some parts of our results with this content outline here. So just by way of introduction, leprosy, as we know, this session is basically about stigma, disability, and the rest of it. So it's a highly stigmatizing conditions, both from community members, even in endemic settings like here in Nigeria, and as well as even by persons affected by leprosy. So our discussion today is really going to focus on the intervention that we did working with persons affected by leprosy, because oftentimes they have a whole lot of internalized stigma and low self-esteem. And understandably, this stigma and even discrimination is exacerbated by visible impairments or disability. And we do agree that, in working towards achieving zero stigma, zero discrimination, there is need to actually generate evidence for pragmatic, approaches to actual stigma reduction efforts, that's really work. So the setting of this study really was understanding that leprosy seems to occur in endemic settings that have low literacy levels. We're wondering, what would it be if rather than use traditional written health education materials, you actually have them audio delivered, which is what gave rise to our research question, which was to assess the impact of audio delivered versus written health education materials on perceptions about leprosy. So my discussion today is really going to focus on just one of the research components, because we've shared some of these results in the past, which is to assess the impact of the participatory developments of the audio and written interventions on empowerment and internalized stigma of persons affected by leprosy who developed these interventions. So what exactly did we do? It was really a cross-sectional activity that we did, where we had 20 persons who participated in co-creating these health education intervention materials. And alongside with these 20 persons, we had 5 community members who were representative of the target end users, because the materials are going to be used, distributed to the community members. And then that was a separate part of the study. So in addition to them, we had representatives from the National and State Leprosy Program staff, and then we had facilitators who were researchers that helped to actually coordinate the development process. And so because the persons affected by leprosy are really non-researchers, just persons affected, and that was just really basically about it in terms of criteria, and people who were willing to participate in this activity. So what we did was to apply the 6QID methodology, which is well-established framework that uses logically uses evidence-based to develop interventions, based on evidence. And there are 6 steps, but I can assure you that it's really not as linear as it looks. There are a lot of iterations in practice. So really, to summarize, what we tried to do was really just 2 things. We wanted to generate targeted health education content co-created by persons affected. And at the same time, we wanted to objectively assess the impact of this co-creation activity on their self-esteem and internalized stigma. So to do that, we had to use several tools. So we used the Leprosy Adapted Internalized Stigma of Mental Illness scale, which is a 29-item scale, alongside with the Rosenberg self-esteem scale. And then there was a KAP questionnaire. So we did this assessment as a mixed study, because there was also a focus group discussion to be able to explain the findings. By way of a timeline, I should mention here too that we had a 5-month no-cost extension, which gave us the opportunity to do a second follow-up evaluation. And that was really helpful because we were able to record both the short-term and the long-term effects of this intervention. So if you see the picture, this picture depicts the setting where it happened up north and down in the south, because the project actually happened in 2 different settings in Nigeria, both in the northern part of the country, which was in Taraba State, and then in the south in Calabar State. The 2 settings are very, very different, both geographically, language, up north to speak Hausa, down in the south to use the Nigerian Pidgin English. So I'm pleased to share the results of this activity, and here's what it looks like. So by way of demographics, we did lose 2 patients, 2 persons affected down the line by 1 year later, by the end. So the average of 6 years old was a fairly balanced proportion of by gender proportion, slightly more females. Most of the participants had formal education. Most of them were married and self-employed. MB leprosy is what many people among the participants, and then most of them also had visible impairments and disability. So if you look at the graph by the right, it perfectly describes the results that we obtained from this, because by the time we plotted, at the baseline, mid-term, and at the end term, which was 1 year later, you could see the knowledge score didn't exactly change much, which was interesting, because by the time you compare it to what we found, in terms of their self-esteem and internalized stigma, there was quite a drastic difference. And understandably, internalized stigma, going in the opposite direction of the self-esteem, because while they had better opinions of themselves, then obviously internalized stigma significantly reduced. And so to explain the results, it's as a matter of fact, even in interacting with them 1 year later, we weren't surprised eventually when we did this analysis to see the results. And I just have a few comments here to just read by way of quotes. So a male participant said, "When I was having the challenge of leprosy, I felt ashamed to go close to people, even my wife and my children. During the ancient times, you would hear different kinds of stories of what happened to people with leprosy. I was thinking that all of them, as family members, would be infected with it. That's why I always go far from them. But presently, since intervention, as I go back home, the first assurance I give them is that disease is curable and cannot be transmitted since I'm on treatments. Now I'm associating with everybody in the community, even the youth leader, chairman in the community today." Okay, so for time's sake, I'll just read one more. Somebody said, a female participant said, "Before I came here to be educated about leprosy disease, people of my community used to speak insulting words to me because of my condition. But after the last meeting, I went back home. I didn't bother again with the words they said to me because I've been educated about the disease and its mode of transmission. So I've been educating others as well, and I'm happy to be here again today." So by way of output, this is what their content, this is what the content actually generated. He actually had, like I said, there were several iterations, trying to actually represent this exactly the way they captured it. So the animations were a narrative that they actually constructed based on their experience, combined with the facts that we had elicited from the baseline survey in the community. So this was a very targeted health intervention social behavioral change materials that came out of it. So both in the audio form as well as the written version. We do have this now being distributed. We generated an XML version of the translated tools. I should have mentioned we did translate some of the tools these tools that were used for the assessment. And that is currently under review because submitted it for publication. We've had the privilege of several dissemination opportunities, apart from peer-reviewed publications, those that are still under review. As a closeout meeting, we hosted a national webinar, which was graced by the Director of Public Health, Federal Ministry of Nigeria, alongside with other stakeholders, even persons affected and key stakeholders as well in leprosy program in Nigeria. Last week, an abstract that was submitted to the upcoming National NTB Program Managers meeting to hold in Togo was accepted. IOC just gave a feedback that abstract was accepted as well. And we did feature in the last global skin NTD meeting. So just as I conclude, we strongly recommend that meaningful application of participatory approaches is a sustainable lens for inclusive involvement of persons affected by leprosy, is empowering infectious long-term reduction of internalized stigma and improved self-esteem. So I'd just like to end with this quote by Maya Angelou, which says, people don't always remember what you say or what you do, but they always remember how we made them feel. And I think that just captured our experience from this project. So on that note, thank you so much to LRI and the rest of the team. Thank you.
Thank you so much. Are there questions in the chat? I don't see in Q&A right now. I have.
No, there aren't any yet.
Okay, I have a question if I could ask.
Good. Yeah,
really
please.
quick. So, and it was interesting that the knowledge hadn't changed that much. Do you think that's because the people involved already had some knowledge in advance and it was more that their self-esteem improved, but or could there be another way to measure that knowledge that wasn't captured? Because it seemed like they had quite a bit of knowledge about leprosy themselves.
Yeah, thank you so much. Really a good question. And we also did explore these options because really, so it turns out that I think the best way we've been able to articulate some form of explanation for that is the fact that, beyond just the experience, it seems, beyond just the knowledge in terms of trying to change wellbeing or not, it was more like the process, because it was actually a marathon. This was like a 7-day, it wasn't just like a 1-day thing. It didn't feel like a one-off, come get trained and, and all that. So it was really very participatory. It was very, very hands-on. They did this by themselves. The findings we had from the baseline, we tried to just dumb it down to the simplest basic way. So it was very conversational, it was very practical. It wasn't so much, it didn't feel like an academic exercise in any way. It was really them just, what do they already know? And then a little bit of the addition, so there was a small change, but it really wasn't statistically significant, in terms of the difference. So yeah.
I also had a question, Gozi, but because originally the intention was to compare audio delivered and written messages, isn't it? Maybe I missed that in your presentation, but I didn't see that comparison. Or is that still to be made? How is that working out?
Yeah, thank you so much, Wim. No, you didn't miss that. Actually, like I mentioned at some point that we did have several research questions. So I was just speaking to this component that was on the participatory co-creation. So they created these messages for community members. At the baseline, we had like over 800 community members. So that was like a separate study of its own. I did that presentation at the last LRI meeting. And then the outcome in terms of the comparison of the audio, to the written, I think is yet another interesting part of the study. We are still completing the analysis of that. So I didn't speak to that in this presentation. Yeah, thank you.
Very good, thank you. And you presented, wait a minute, here we have a question just popping up. Dr. Becky Rivoire from Hope Rises International says, most of your participants were educated. Would you expect similar or different results in a more rural environment?
Thank you so much. It's a very great question, really. So I think we actually, our participants were actually drawn from different parts of the community. It wasn't just rural community. It wasn't just urban communities. We actually had mostly rural settings. But then they had, by way of formal education, what we actually pegged it off was the basic education, so up to primary 6 level. So in terms of difference, expecting a different result, I really can't tell. I think we may have to be more intentional to try to include category of people who probably do not have any form of education or have much less level of education. So, but this was what we found in our setting. Thank you.
Thank you. Yes, and there's also 1 or 2 things in the chat here. Joanna Abdu is asking, is there any difference regarding the leprosy perception if you are to compare to the northern part, and if you're to compare the northern and the southern part of, I assume this is about Nigeria.
Oh, okay. Yeah. I think I get sense of the question because, like I said, the study was actually done. It was like 2 exact studies happening like a mirror image, like a replica of each other in the north and in the south. No, but for this particular component, we didn't do a sub-analysis because really our numbers were quite small. So it wouldn't have been very practical or it could have even given a misleading result if we tried to, break it down. The numbers were too small to do that, so we didn't do that.
Fair enough. Yeah. I think that's our questions, Cassandra. So thank you very much, Ngozi, and it's back to you.
Thank you.
Thank you. Okay, the last presentation today is Mr. Marekegn Habtamu from the Leprosy Mission International Ethiopia, addressing leprosy trauma using the Traumatic Stress Relief Program, an exploratory trial with persons with lived experience in Addis Ababa, Ethiopia. Thank you.
Okay, thank you, Cassandra and all. Thank you all. This is Marekegn Habtamu from the Leprosy Mission International Ethiopia. In this LRI project, my role is research coordinator. So as you have seen, the title our study is Exploratory Randomized Control Trial of Traumatic Stress Relief TSR Intervention with persons with lived experience of leprosy in Ethiopia. This is my presentation overview. So when we come to the background of our study, so leprosy is one of NTD, and it causes also a significant illnesses, and it also hinders the economic development of the affected peoples. Still, despite there are a lot of efforts, leprosy is still a public health challenge for the global community. So the recent WHO report indicates that over 200,000 new cases were reported across the globe. So when we come to the Ethiopian burden, so Ethiopia is one of the top 23 countries in leprosy endemic, and also the recent report indicates that over 2,500 new cases were reported. So the disease imposes a visible impairment in stigma, so which will affect the well-being of the affected peoples. Despite there are quite a lot of studies intended to investigate leprosy-related issue, most of them mainly focused on primarily focused on the physical aspect of leprosy, and there are a little bit studies which are intended to address the mental health impact. So when we try to see some literatures indicate that there are some evidences which shows the need for mental health intervention. Sony and his colleagues report indicates that more than 14% of the participants showed moderate to severe depression. Also, other study indicates that more than a third of study participants showed mental health difficulty. So these studies indicate that the need for mental health intervention. The challenge is there is a need for mental health intervention, but in resource-limited settings, there is a shortage of mental health professionals. For instance, if you take our scenario, the recent atlas indicates that one psychiatrist is for about 2 million people. So the mental health professionals are very scarce in our setting. So WHO advocates to scale up psychological interventions like TSR, which can be delivered by paraprofessionals or frontline healthcare professionals. So TSR is a type of mental health interventions that can be delivered by paraprofessionals or frontline healthcare workers. And this intervention had been tried in different settings, and it had shown a very promising result. So the research, the objectives of our studies, one is to explore its effectiveness in persons affected by leprosy. The second one is to assess the feasibility of the intervention. And last objective of our research is to evaluate the training, how to evaluate feasibility of the training paraprofessionals and peer supporters in the TSR intervention. So when we come to the methods of our study, the study design is exploratory randomized controlled trial. It's not a full scale. So it's also compounded with qualitative study. So for this exploratory trial, we designed a sample size of 100 study participants with 1-to-1 ratio between the two groups, the intervention and the control groups. So we've set also some inclusion and exclusion criteria. Inclusion criteria is age over 18, willing to provide informed consent and take part in this study, permanent resident in the study area, and PHQ-9 score lower than 14 will be included in our study. And we have set also some exclusion criteria, psychosis, suicide. These are a bit more severe conditions of mental health. So this intervention is not intended for such kind of mental health problems. So we exclude these peoples in our baseline assessment. When we came to the data collection technique, we're going to employ a mixed approach. So for the quantitative study, we're going to use like socio-demographic capturing questionnaire, ITQ International Trauma Questionnaire, Anxiety Questionnaire, PHQ-9, and KFA acceptability of the intervention questionnaires will be used for quantitative data collection. On top of that, we're going to support our quantitative result with qualitative studies. So we will undertake interviews and FGDs, because this is a picture that shows the training session when we were delivering this TSR training for those paraprofessionals and for those peoples who are affected by leprosy. So when you come to the data analysis technique, so the quantitative studies will be like the socio-demographic data will be analyzed in descriptive statistics, and repeated measurements ANOVA will undertake to compare the groups, and the design, the effect size of the intervention will be estimated by Accordance D measure, and framework analysis will be used to analyze our qualitative data. So this research project is not yet progressed. Now we're recruiting study participants according to our inclusion criteria, but when we see its progress to date and the next steps, so staffs, including me, including myself, staffs were recruited, materials. So this TSR intervention was tested in different settings, but we haven't adopted that in our context. So the materials were adopted, translated, and tested in order to make them compatible with our context. TSR facilitators training were undertaken in Alert Hospital. So for these paraprofessionals, we try to organize some rehearsal practice sessions in order to accustom them this intervention with their practice, and study participants are now recruited. So the next step is we're going to deliver this intervention in a group setup. Then after delivering while we're delivering the intervention, there is a senior mental health professional who is going to ensure the fidelity of the intervention to maintain the quality of the intervention. Finally, after delivering the intervention, we will undertake post-intervention data collection, data analysis, and final reports and manuscript writing will proceed. So the implication of the study, one, this is exploratory study. It's exploratory trial. It's not a definitive trial. So we can use this, our finding, as foundational study to design definitive trial, or to design a very scale-up trial. So the other implication is it will bridge the literature gap. It will bridge the literature gap. The other implication is to develop like public health strategies, and the other one is to develop a comprehensive care model that addresses both the physical and the mental health needs. The other is social related impact. As you have seen from the previous picture, we were offering the training combining these persons affected by leprosy and those paraprofessional mental health professionals. So this would enhance the inclusion of these affected peoples. So lastly, we acknowledge LRI for funding this study. The associations of persons affected by leprosy, this is ALDRA, so this is the Addis Ababa association. We also acknowledge Alert Hospital. They provide us space to undertake training for recruited TSR facilitators, and this research article is an output of this project. Thank you very much.
Thank you so much. Yeah, continue to put your questions in the Q&A. And are there any questions currently for this presentation?
Question again from Becky Rivoire. How will you recruit your participants, assuming that it is addressed to Marekegn? Can you respond to that question, please?
Yes. What we did to recruit this our study participants in collaboration with the association, which I've mentioned earlier, we organized like a psychoeducation, like a basic psychoeducation for persons affected by leprosy. So in that occasion, aside to the psychoeducation, we try to interview those participants. Through that process, we recruit our study participants. There are already tools which I have mentioned in the meta section. So using those tools, already the tools are very validated tools. They have been used in various settings, including Ethiopia. So by using that, we try to, we identified our study participants.
Mm-hmm. Thank you.
You're welcome, sir.
I was also wondering, you on your slide on study design, you called the study an exploratory randomized controlled trial. Now, I think I understand what you mean by that, but it may be useful also for future presentations and publications if you would call it a proof of concept study, because that tends to be the more common name for such a study. Or was there a reason? Did you consider that name, and did you decide to use the other name for a particular reason?
Just for this study, we coined as exploratory. So far, we don't have any evidence related to this study in our setup. So we're going to explore both in quantitatively and qualitatively. That's why we coined our topic in such way.
Right. Yeah. I think generally people call that a proof of concept study or a proof of concept trial.
Yeah, sure.
Any other questions? I don't see any in the Q&A at the moment.
I have a question for Moges. I think from your study, from presentation and your report that you mentioned that podoconiosis and lymphatic filariasis, people talked about a lower quality of living, or look on the survey, than leprosy. One of the reasons might have been the economic cost, economic burden, but also the participation in leprosy associations. And are there any for podoconiosis and lymphatic filariasis, or could people with those, those diseases, if they have those problems, conditions, could they also participate in a leprosy association? Is that a possibility?
Yeah, just previously, those podo and LF cases were not participated in association, but now by our project, we established 5 podo and LF association. Previously, INAPAL established association on those persons affected by leprosy.
Mm-hmm.
Yeah.
Oh, that's great. Thank you. Yeah, I know there are also some questions that Marlies, I think you answered them in the chat, so people can, or in the Q&A. But I don't know if you want to say anything more about those questions and about, let's see, stigma reduction interventions suggested by local populations.
Yeah, thanks. Yeah, I answered them in the chat. But indeed, so one point was whether we engage local populations, but yeah, to clarify, we didn't develop the interventions ourselves. I provided some examples that could be a next step, which for that would indeed, the engagement of local populations would be important and key. And in terms of the second question, that was on, what organizations or peer support groups could do to engage with these findings. So just to go back very quickly, is we found that family support and engagement could be a key nexus point for the mitigation of stigma, but also the worsening of stigma. So what this highlights is that, these experiences and engagements within the family can be kind of the locus where stigma is felt most powerfully. So I think for this context in far Western Nepal, that can be just a focus area within support services or in peer support to discuss this and focus on this, because it can be, that doesn't have to be, very impactful in one's life. At the same time, there's lots of information campaigns, of course, or information services, and our findings indicate that, okay, maybe we should really specify these in these contexts to focus on the family, for example. So that can be another example. Or in peer support, see if it is possible, and if we wish, that can differ, of course, per person, to engage a family member in a peer support trajectory, yes or no. Because one example, that's the last thing I'll say, is respondents shared, for example, that girls tend to receive less family support or receive the support later, which then delays their access to care, which can have impacts on their health, well-being. So that can also be, focusing on these girls, these women. The support of family can have a great impact there to make sure that they access care timely.
Yeah, I think that that's also the experience of Moges and his team in Ethiopia. They've worked with this family-based intervention for quite a few years now, and I think that generally seems to be very successful way of approaching it. And I guess it also intrinsically then means that the family will focus on what they consider the most important thing. So what matters most is, as it were, built into the family. What I also thought was interesting is, maybe you can say a bit more about that, is any, say, preventive effect, because it is one thing, of course, to try and do something about problems that have arisen, but if we can somehow, by involving family, we can prevent problems from happening. Can you say a bit more about that?
Yes, good question. I think so. We haven't studied this as this was not the focus of the study, but of course, I do think this can definitely be relevant. I also feel like it doesn't have to be only targeted to leprosy, right? These interventions, I think they can be relevant for various health conditions. Yeah, I wouldn't know because we didn't study it, the effects on prevention. But I do think definitely in terms of health behaviors, accessing time or awareness information sessions, or engaging, for example, community health workers that go to families before a health condition manifests. I think, yes, definitely it could be useful. The how, I think, would be a next question for additional research. Yeah.
Moges or any of the other speakers, do you have any experience in involving family at a very early stage so that it might work preventive? Not everybody raises their hands together. Yeah, maybe that is an area for future work, right? It seems we don't have any questions in written questions anymore, Cassandra. I don't know if you had any more yourself.
No, I think that's it. I don't see any more questions.
Yeah,
But I wanted to just encourage everybody to continue. If you think of a question later for the audience, you can, through our online platform, the LRI online platform, you can send direct chat messages to different participants in this and even initiate a video call. So you can kind of continue the conversation afterwards. So if there's nothing else, we'll kind of conclude this session, and thank you all for coming and wonderful presentations. Really enjoyed these, and thank you.